morning, everybody, and welcome to the Neuroscience's Grand Rounds. There is no commercial support for today's program. The planners have disclosed no relevant financial relationships with commercial interests. However, Dr. Grunch will disclose her relationships in her presentation. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. If you are attending virtually, you may enter your question into the chat, and we'll read it during the Q&A. A link to the event survey will also be shared at the end of the program. And now it is my pleasure to introduce our guest speaker this morning. Dr. Betsy Grunch is a board-certified neurosurgeon who attended the Medical College of Georgia in Augusta. She completed her residency at Duke University, where she also earned the Synthes Spine Fellowship from 2010 through 2011, and has been working at the Longstreet Clinic in Gainesville ever since. She was honored as a woman marking a mark in 2023 and has been listed as a top doctor for several years running by Georgia Trend and Atlanta Magazine. Her main interests are minimally invasive spine techniques and advancing the field of neurotrauma. Additionally, Dr. Grunch is known online as @LadySpineDoc, where she enjoys demystifying the subject of neurosurgery while also showing her audience how she balances work and life as a mother, wife, and friend. Her thriving social media platform seeks to empower the general public with critical medical knowledge to inspire current and future healthcare professionals and to add a bit of positivity and humor to your day. Please join me in welcoming Dr. Betsy Grunch.
This hospital means a lot to me. Obviously, I was born and raised here, but a long time ago, this facility treated my mom for an injury to her spine that I'm going to talk about. So these are my disclosures. So this is a picture of us. This is me and my mom. This is me and my daughter here. So in 1994, I was 13 years old. I went to West Hall High School, which is about 15 miles from here. My mom was a Hall County Sheriff's deputy. She has worked for this county since she was 21 years old as a sheriff's deputy, also as a dispatcher. She was also a member of the Honor Guard and of the dive team, search and rescuing people from Lake Lanier. So she was pretty cool. And then around the corner at Chicopee Woods one night, August 17th, 1994, she was injured. Her car hit a tree. This is pictures of her car. So some pretty significant damage. She was C4 quadriplegic. She came into our emergency room in the middle of the night. It was about 2 a.m. And I'll never forget that time. They woke me up that morning and my aunt said that my mom had been in an accident and that we needed to go to the hospital. So we came here. There was no North Tower at this time. This was only the South Tower as we knew it, the medical center. And she was up in the ICU, intubated and facing surgery. And I remember Dr. Mahana, who is, for those of you that have been around Gainesville a long time, has essentially been the mainstay of neurosurgery in this town for a very long time. He was sleeping and they couldn't wake him. They couldn't reach him on his cell phone that night. So the deputies actually had to go to his house to get him to come in once my mom came in on the injury, and he treated her throughout her hospitalization. She was C4 quadriplegic, and it's really changed everything obviously about her life, but about my life too, and has really given me the passion to do what I do. And so just want to kind of talk about these injuries and why they are so important and why the treatment is. So just to kind of go through a few cases, these are all my cases, all at this hospital. And we see these cases all the time. And I was on call this weekend and saw several actually and operated on several. So it's not uncommon, and it's something that I'm very passionate about. So this is a 29-year-old guy who, like many of us, dive into water not expecting that they're going to wake up, hit the bottom of the pool and become quadriplegic. But he dove into the pool, and you can see he has a C4-5 fracture dislocation there. And it came in incomplete. And I'm going to talk about what that means. Essentially, he had severe tingling in his bilateral upper extremities, some weakness in his delts and biceps, and had absent function in his legs. So here's his level of injury. This one, 17-year-old, I'll never forget this case. He was driving in his car with some friends and was in an auto accident, going too fast because he's 17. He's a boy. They don't make the best decisions. And he hit someone head on, was partially ejected out of the sunroof. So essentially his upper body this part was out the sunroof and this part was under. And he had a fracture dislocation at T11 and T12, one of the worst spinal cord injuries I've ever seen. Not only, obviously, was it a catastrophic injury, he's paraplegic, but it was actually one where the spinal cord was completely ligated and everything. I'm just grateful that he didn't pass from this injury, from vessel injury. It's shocking, but I treated him for a long time and continue to treat him for this devastating injury. This is another one. These are the more common ones we see. This is a 70-year-old who was in a rollover MVC, and she comes in with 4 out of 5 strength in her delts and biceps, and delts, and then 0 to 5 in her biceps and the remaining uppers, and still some preserved sensation in her legs. So she was kind of weak, but not what we would call quadriplegic or complete injury. And this is her CT scan on admission. This is a more catastrophic one. This is a 44-year-old that was ejected, and he had 0 out of 4 strength, essentially complete. And the only thing that he could do was at the time of arrival is breathing, no movement or anything anywhere else. So these are all grades of what we call the Asia spinal cord injury classification. This is the way we identify spinal cord injury. And they're not all like this. The 2 cases that I took care of this weekend were both older women who both had ground level falls. And I would say falls are probably one of the more common reasons in MVCs, like I said, because, as we get older, we tend to lose our balance. And as the one patient I had this weekend just simply tripped in a 1-step in her home. She had one of those step-down living rooms. I don't know why we still have those houses were built like that, but that step-in living room. And she just missed a step and broke her neck. And then the other one was just a fall off of her bed. She kind of rolled out of the bed the wrong way and landed on the back of her head and had a devastating injury as well. So how we grade spinal cord injury, it's kind of complex. This looks a little overwhelming, but it's really kind of simple. I mean, essentially what we do is we find out what their motor function is, and that's of each muscle group. So C5, C6, C7, blah, 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 all the way down to the lumbar spine. And we make these in easier cards so you can identify. But essentially, you're trying to see which muscle groups move and which don't move, which ones are weak or which ones are normal strength. And then light touch, so gauging their sensation in every single dermatome. This is the dermatome man. If you're in neuroscience, you've seen this and know this well. And then you also want to test sphincter tone. So as a neurosurgeon, it's really the only time I ever do a rectal exam is whenever I'm trying to gauge a spinal cord injury. So you want to know if they have perineal sensation, if they have tone in their rectum, because those are also important in the Asia scoring. So there's Asia classifications A through E, and Asia E is basically no injury at all, completely normal. And Asia A is devastating injury, complete. So wherever they broke their spine, there's no motor sensory function from there down. And then there's B, C, and D, which is a little bit in between. So you'll have, this is like less devastating injury. Asia D would be that they have some motor and sensory below the sensory tone, below the level of the injury, but the muscle grade is 3 or more. And then this is same, just 1 step down. And then this is no motor function, but they have intact sensation. And based on these injury classifications, we can gauge what the recovery may be like and their chances of recovery. So, and when you're speaking physician and a physician, these scores can be very helpful. There's other clinical syndromes that I'll go by too, which don't necessarily fit this: central cord syndrome, Brown cord, anterior cord cauda-equina syndrome, which we also see a lot on call. I actually had a case of cauda-equina syndrome this weekend as well. So the types of spinal cord injury, how do we define them? What do these words mean? Tetraplegia or quadriplegia basically means that there's loss of motor and sensory function in the arms and legs. Tetra or quad means 4, so all 4 extremities. This can obviously be the worst of all spinal cord injuries. And you have paraplegia, which is essentially an injury usually from T2 or down, because it only affects the legs. The arms are preserved. And this is a little bit easier to function independently with this type of injury. Then you have the more unusual types of spinal cord injury that don't necessarily match these qualifications. It's pretty easy if somebody comes in the emergency department and they're not moving their legs to say, okay, this person has a spinal cord injury. But some of these other ones can be very hard to diagnose, or I've seen misdiagnosed. Central cord syndrome, I would argue, is probably the most common of these. If any of you take trauma call or treat trauma patients, see this all the time. So basically what a central cord syndrome is, it's typically an older person. It's someone with pre-existing degenerative disc disease. All of us in this room have some varying levels of stenosis. I can guarantee if we MRI'd every single person in this room that none of you would have a normal MRI. Some of us may have bad stuff going on and we don't even know. And so this is what happens. You can have someone with pre-existing kind of disc bulges, whatever. They fall and then they kind of ding their spinal cord because of that disease and start to have these kind of odd symptoms. So what happens is the central part of the spinal cord gets injured, and that is the function that does the sensation just we call it the cape-like distribution, but just in the chest and arms. And they'll get some loss of dexterity usually in their hands and an incredible burning sensation usually because it disrupts the pain pathways. And so patients will usually come in sometimes only complaining of tremendous pain in their hands, tingling in their hands, or weakness in their hands, but everything else is normal. And I've seen a lot of these get missed as a spinal cord injury because sometimes you do their CT scan in the trauma bay and their scan's normal because they don't necessarily have a broken neck. And then these things, cannot get treated correctly because they weren't diagnosed correctly. And what they really need is an MRI of their cervical spine. So if there's any kind of concern for neurological complaints after a trauma, it's so important to get an MRI scan to have a look. I've seen the most common thing that I see these kind of injuries are older folks with ground level falls because they're going to have some type of pre-existing disease, and it can be a very minor trauma. The patient that I had this weekend was actually the one that I mentioned fell out of bed and had a pretty significant injury, went to our local next door neighbor hospital. I won't name who it was. And they just did an x-ray and said she had neck pain and some tingling in her hands. They just sent her home. They said, "You're fine. X-ray looks good." And she went 2 days before she could no longer walk because her neck pain was so severe before she decided to come up to our facility. And thank God she did because she got a scan and was in surgery that day. So she had a pretty devastating spinal cord injury that was missed because no one listened to her. And listening to patients is so important in trying to detect neurological injuries. Brown-Séquard cord syndrome, this is pretty rare. I can't even remember a case that I've seen of Brown-Séquard cord syndrome, but we like to teach it in medical textbooks. It's essentially a hemicord lesion, so you damage only half the cord. And most of the time, it's classically described in penetrating trauma, like someone stabs and only injures half the cord. The chances of that happen are extremely rare, but it is a common teachable thing in it, mostly because you learn about the neurological symptoms by how this can get damaged. And what happens is you get loss of movement on one side and loss of pain and temperature and sensation on the opposite side at the level of the injury. So if it happens in the neck, you'll get both arms and legs. If it happens in the mid-back, you'll get loss of sensation on one leg and then loss of motor on the other leg. Anterior cord syndrome, not as rare, but we have arteries that penetrate our spine and supply our spine. So think of this like a spinal cord stroke. We do see it in patients with vascular disease. I was told that you guys talk a lot about stroke in here. So we'll talk a little bit about spinal cord stroke. But essentially, if you have vascular disease, or even if you have a dissecting aortic aneurysm, or you have embolization done for another procedure, you can get an injury to the anterior cord. And there's even something called surfer's myelopathy, which is kind of cool. I love to teach about that one, but it's a hyperextension. Like if you're laying on a surfboard, kind of arching your back like this, you can dissect the anterior, the artery of Adamowitz that supplies the cord and can get an ischemic cord. So basically, it's a loss of motor function with preserving proprioception. So it's really kind of unusual. And as anatomy would have it, we only have one anterior spinal artery and we have two posterior spinal arteries. So the chance of a posterior cord syndrome is extremely rare because we have two arteries, but on the anterior part of our spinal cord, we only have one. Cauda equina syndrome, very common. It's basically typically a large disc herniation in the lumbar spine that can compress the cauda equina, and the patient can have loss of bowel and bladder function and pain in their lower limbs. And this can also be, if not acted upon, can be devastating with loss of bowel and bladder continence for the rest of their life. So I've also seen some of these patients missed and not caught in time. Typically, we want to take them to surgery within 12 to 8 hours. And if they're not taken to surgery quickly, the chances of recovery go down tremendously by each passing minute. So these are things that need to be acted on quickly. If someone comes into the emergency department, complains, hey, I just peed on myself and didn't know, people tend to get pretty riled up about it because this is a medical emergency and it needs to be diagnosed correctly. Now, the amount of times that people have back pain and acute urinary incontinence is actually pretty common. You herniate a disc and you have a lot of pain, it can cause you just out of pain to urinate yourself, but it can get you a pretty stat MRI just to make sure that you don't have this syndrome. So a little bit about spinal cord injury. I like to talk, so I'm going to have to try to talk fast. There's about 17,000 spinal cord injuries a year, and 78% of them are males. I won't say why I think that is, but you can read between the lines that most of these things are the causes of spinal cord injury. Falls, 32%. Vehicle accidents, MVCs, 38%. Violence, pretty rare, 14%. Sports injuries, medical and surgical, etc. So if we look at those cases, 4,000 of them die before reaching the hospital. I had a friend of mine when I was a resident at Duke that was my spinal cord spine rep. The vendor brought in the trays and whatnot. He was hit head on at 28 years old with his family in the car on Christmas Eve, suffered a C2 spinal cord injury and died on the scene. So that's what happens with high cervical injuries, particularly. You can go apneic, lose your airway, and not make it to the hospital. 1,000 of them die during the hospitalization because the injuries can be so severe. And you think about patients that have such a significant trauma that they sustain a spinal cord injury, they can have other injuries that may be life-threatening. If we think about how many people this is, it's a lot of people. The average age is 28 years old prior to 1980, and since 2005, it's gone up tremendously. And that's just because how many people survive with spine disease as older folks, and now we're seeing more and more injuries like this in people that are older. So prior to 1980, only 5% were older than 60, and now it's almost 12%. 77% are males, like I said. Ethnicity, mostly Caucasian, 22% African American. And the causes are, like I said, spinal cord injury, work-related, etc. Falls are the most common cause in older people. Car accidents are the most common cause in younger people. Alcohol, 25% of the time. And this is an important statistic, but 25 to 57% have other confounding injuries. 25% of them will have a traumatic brain injury. That's because if you sustain a trauma that's significant enough to break your neck, you most likely had some type of intracranial injury too. And these compounded spinal cord injuries plus TBIs are some of our most challenging neuroscience patients to take care of. Most of them, 55% of them, are cervical injuries. And that makes sense because if you have a bad car accident, your neck is typically the one that suffers a lot of the impact and whiplash type injuries. But then, the rest kind of fill in the equal parts. 45% of people are in Asia A. And if you guys remember, that's the worst spinal cord injury. That's a complete injury. And then the least severe is about 30%. So about half of those patients that we see with spinal cord injuries are complete. 57% of them are employed at the time of surgery. 50% of them are single. Remember, we're talking about usually young men. 1/3 of them will remain single post-injury. It's very hard to maintain a relationship whenever you have to be taken care of. And I can talk about that in a little bit. Divorce rate post-injury is 2.5 times the normal population. You can imagine also a spouse that can be persistent and help take care of someone. There has to be a very, very strong pre-existing relationship there. It's very hard. 40% of them, less than a high school degree. That kind of goes along with decision making and how these accidents can sometimes happen, and the age of the people at the time of their injury. This is important because life expectancy post-injury is lower. If you think about someone with a high cervical spine injury, there's so many comorbid complications that can happen at any point in their life. Pneumonia, cardiac, other traumatic injuries, septicemia, we see that a lot of. Patients with decubitus ulcers that come in because they're not taken care of. They get a bad, even if they are taken care of. My mom's had many surgeries for decubiti. It's just a natural part of not being able to move. Suicide, we don't talk about this a lot. These patients have a lot of mental health issues. You can imagine if you're a very functional person and then you are neurologically devastated with an intact mind, that doesn't go well. My mom has attempted suicide twice. And I actually know a friend of mine whose husband's was a quad for 25 years, and 2 years ago he killed himself after being in a wheelchair for 25 years. It's a hard thing to deal with. And that doesn't just happen right after the injury, it persists lifelong. Lost wages per year, obviously, these patients can't always go back to work. So tremendous loss to society as well as to the patient. So the good news is that trends, there is decrease as we're getting better at treating these injuries. There is decreases in hospital length of stay, rehab length of stay, but there has not been a positive change in life expectancy. And I'm hoping there's been, some very exciting research even in the past 1 to 2 years on spinal cord injury. We can talk about Elon Musk's Neuralink and what that might mean. There was also a clinical trial that just got approved for stem cell in the United States. It was just released about a week or two ago. So those are all very exciting things that may change, in the next 10 to 20 years of how we take care of these patients and expected outcomes. And somebody may be on the stage giving a very different talk. So that's exciting. So what are the goals of treating patients with spinal cord injury? Did that get loud all of a sudden? I think this is really important as providers because, of course, we want to save their life, but you want to try to preserve and maximize neurological function. So what I mean by that is if they come in and have an injury to, let's say, C5, and we maximize medical care and we can preserve that injury, C5, C6, maybe they'll stay. But if we don't maximize our medical care, sometimes the secondary injury to the cord, maybe a little bit of swelling, they can become a C4. Being a C4 quadriplegic is tremendously different as functional status as a C5 or a C6 quadriplegic. And I've got some examples later in the talk that I think that'll help illustrate that point. So what we do during their initial stay to preserve their level of function can affect the rest of their life tremendously. And I think that's really important to know as providers because we only see them here for the first 1 to 2 weeks that they're here, and you don't know what life is like for them as they go on 10, 20, 30 years out from their injury. And the medical care that we provide in the first 24, 48 hours, first week, can really affect them lifelong. Of course, stabilizing the vertebral column is important. So in the field, preserving life, the ABCs, stabilizing their spine, log rolling orthotics, we're pretty good about that, but I'll be perfectly honest, we're not great at it. I had a patient 2 weeks ago on call, a morbidly obese man, missed a stop sign in a dump truck, rolled out into a field, and he had back pain and saddle paresthesias at the accident. He told paramedics his back hurt. They made him walk from the dump truck to the road to get an ambulance. And when he got here, he had a burst fracture compressing his cauda equina that was very severe. And I can't help but wonder if he was put on a spinal board at the truck and then taken. I can only imagine maybe they didn't want to carry him because he's very big, but would that have made a difference? So anybody that complains of back pain on the scene as a first responder with any type of accident, it can be even the most minor accident, neck pain, whatever it is, it's so important to initiate spinal stabilization the minute that they're on the scene, because any kind of ambulation or manipulation of their spine can really make that worse as they get to the hospital. Obviously, it's better to get patients to a trauma center, and there really isn't a difference in air flight because these are very important things that need to happen. Minutes don't necessarily matter by stroke, but hours can definitely matter. We talked about this earlier, but gauging their spinal cord injury and doing a very thorough neurological exam at the time of injury is extremely important to know what you're dealing with. And these are things that need to be done in the emergency department. And these are things we need to be teaching our emergency room providers. It's hard for me as a surgeon on call to get that call, and then patient, they get a call from, let's say, the trauma intern. They're moving their arms, but they're not moving their legs. Or are they moving their biceps? Are they moving their triceps? Are they moving their intrinsic hand function? They're open and closing their hands. Are they able to extend their arm? Are they able to shrug their shoulders? All those things are completely different things. You can't just say their arms don't move, work, legs don't work. Even, talking about saddle paresthesias and the perineum, all those things are extremely important. So a detailed, thorough neurological exam can be performed by any medical provider, not even a doctor. A nurse can do this too. So it's really important to know that these things all matter to us. Obviously, getting imaging is extremely important. This advanced imaging, when you have a patient that comes in with a trauma, we are now a level 1 trauma center. Kind of crazy to think that when I came here in 2013, we weren't even a level trauma center at all. So the amount of changes in how we have modified how we triage these patients is all positive. But almost everybody that comes into this emergency department that has a car accident, whether or not they complain of neck pain or not, are going to get, or a traumatic injury, are going to get a CT scan. X-rays miss 6% of injuries. Remember the woman I talked about this weekend? She should have never have just been able to leave the emergency department with just a plain X-ray. In my opinion, plain X-rays are really for anybody that's having neurological symptoms or having any type of pain are completely useless. CT scans are very important as a first initial triage scanning screen. And then, of course, MRI can help to take more significant injuries. If you have someone with a CT scan like this and complain of neurological injuries, you don't really see anything bad other than they have a really bad neck, but you don't see any compression of the cord or anything like this, no fracture. But this person could have severe cord compression and multi-level disease because of that stenosis that I talked about. So it's important to kind of gauge what imaging studies that they may need. Preserving function. So the pathophysiology of spinal cord injury, we all know the primary injury. That's as soon as they sustain the incident or the accident, that's the trauma to the cord initially. We talk about it in stroke too. It's the whatever the bleed is, the ischemia that happens immediately. That's the primary injury. Can't really change that. Can't undo their car accident. Can't undo their fall. But what we can treat is a secondary injury. And that's the biochemical cascade and cellular mechanisms that happen after the injury that can further promote ongoing neurological damage in both stroke and in spinal cord injury. And these are the things that we really want to focus on treating. So in a patient like this, obviously the primary injury is going to be that trauma to this C4 and C5. And this ongoing secondary injury is a swelling of the spinal cord that can happen over time, over the next 3 to 5 to 7 days or so. Medical management of spinal cord injury is very much like stroke. Talking about autoregulation, the way our body regulates blood flow to our neurological system is autoregulated by our brain and the mechanisms of that. But with damage to the blood-brain barrier, damage to that spinal cord level can disrupt autoregulation, and we want to maximize that perfusion to the spinal cord to make sure that all the nutrients, all the oxygen, all the good stuff get to that level of injury and can promote healing. So these patients need to have an A-line. They need to have their maps pushed, if they medically can, to 85 to 90 millimeters mercury for 7 days. Treat hypotension. They often come into the field. Maybe they had a pelvic fracture. They have lost a lot of blood. They're going to be hypotensive. Does anyone else know another reason why they might be hypotensive? Spinal shock and neurogenic shock. So any injury to the spinal cord will cause a neurogenic or spinal shock, which are two different things I'll talk about here in a minute. So essentially, you can imagine if you have an injury to your spinal cord, some of the nerves that go to all of our muscles in our body, the sympathetics and the parasympathetics, are lost. So all your blood vessels, the ability for them to constrict and to dilate, you lose that function. So then they all dilate, then all your blood goes, kind of dissipates in a more bigger space. So your blood pressure goes down. And if your blood pressure goes down, they can have secondary injury. So we have to really focus on making sure that we maximize their blood pressure to treat those ongoing secondary injuries. Intubation is important. You might have someone that's breathing spontaneously. That patient that I showed with that crazy looking CT scan where the C2 is dislocated, he came in breathing in spontaneously. That's a patient that you look at the CT scan and you immediately intubate. And the reason is because anybody that has, remember C4-5, keep the diaphragm alive. If the diaphragm isn't working properly, these patients, particularly with higher spinal cord injury, can lose their airway, and it can happen quickly. So if you don't emergent in a more controlled fashion, if you don't intubate in a controlled fashion, it can become a more emergent airway and potentially have pretty devastating circumstances. And you can imagine intubating someone with a broken neck can be quite challenging. So it's important to recognize, particularly above C5, that these patients, whether or not whatever we do, 87% of them are going to require to be intubated, and most of them go on to need a tracheotomy. So it's best to do it when it's a controlled airway and not an emergent. Even patients with lower level C7, T1, sometimes just their loss of intercostal innervation and their ability to maintain diaphragmatic control of their chest wall can cause them to really have a hard time breathing and need a trach. It's not usually lifelong. It can be very temporary, from a week to month to whatever. My mom is a C4 quad and it's been trach independent since probably maybe 40 days post-injury. So even though they do have a cord injury, it doesn't necessarily mean that they'll be permanently intubated, but this detecting this early on is really important. The Cochrane Review steroids, these are highly controversial. Not as much now because I think we've all accepted that steroids don't really play a role, but back when I was in training, I won't mention my airboats before this, that this was, accepted that we give everyone steroids, and now it's become more commonplace that that's not really necessarily true. Stabilizing the vertebral column, that's where we come in as neurosurgeons. And I think it's really important to make sure that we stabilize these people urgently. I think there is sometimes the kind of cavalier, like, oh, well, they're Asia A. It's not, the damage has been done. We don't necessarily need to do this urgently because it's not going to make a difference. Someone can go from an Asia A to improved Asia scale. So it's really important to get these patients surgery early as possible. I'll never forget the case of a 17-year-old July 4th weekend. I don't know why I typically take call on July 4th. Need to reassess that. But I had a 17-year-old that got pushed into the Lake Lanier, off the dock by some friends, goofing around, being boys. And he transformed his push into a dive, dove off the dock, instantly quadriplegic. Friends saw him floating face first in the water, thought he was joking. He wasn't. They rescued him out of the water, came in here at Asia A. I took him straight to the OR. It was about noon, and now he's an Asia D. So, and I can't help but think that that emergent case to the operating room didn't make a difference in that. So I think it's really important. They're less than 24 hours are 2 times more likely to have a 2-grade improvement in their ASIA score at 6 months. So facet dislocations, those are the joints in the back of the neck. Sometimes with really traumatic injuries, we can see that those are kind of, think of it like a hip dislocation. It's a spine dislocation. These are important to get reduced. They can be quite challenging to reduce because just because of the nature of how they have to be reduced or the size of the patient, and very risky, as you might think. But close reduction of them with weights. You'll see patients in the ICU with skull pins and weights hanging off their head, and that's a close reduction of the spine. That can make it much easier intraoperatively to get them corrected and realigned. You can do it intraoperatively, but I think it depends on the injury. So if it's a complete spinal cord injury or an incomplete spinal cord injury, any damage to the neurological function, immediate reduction. That means right then there, maybe going to the OR, trying to get them reduced right then. If they have intact, maybe they just have severe pain, but they have a dislocation, or they have arm pain or something like that, you can consider an MRI to kind of look and see what you're dealing with. But these other patients that have a facet dislocation, you probably don't even want to wait for the MRI. And then in obtunded patients, these patients with traumatic brain injuries, you can consider getting an MRI. What you want to be able to do is get a good neurological evaluation pre and post reduction. So if you're trying to reduce them and they have, maybe weakness, and then you reduce them and they go to quad, that's bad. So we want to be able to get a neurological function to know as we're trying to reduce them, are we doing something we should be doing? Should we be stopping, et cetera? Facet fractures that are maybe non-displaced, sometimes depending on the nature of the injury, we can do an orthotic brace, like a neck brace, an aspen collar. But again, if you break the joints in your spine, particularly bilaterally, there's a high rate of failure. So these are patients that will follow very closely. This is kind of a before and after, just showing kind of what sometimes is required. These 3-column injuries often require anterior and posterior stabilization, so it's usually a 2-stage procedure. What we try to do is really get, if they have to have a front back, particularly of the neck, I usually try to get them reduced anteriorly and then give them a few days and come back posteriorly later, because the initial goal is to get the pressure off the spinal cord, but putting them through a large surgery can sometimes affect their blood pressure. So we want to make sure their blood pressure stays high. That gives them the best chance of recovery, and maybe that posterior stabilization can wait. Lots of variables that come in. Vertebral artery injuries, we're pretty good at diagnosing these because CTA is so prevalent now, but these can also be missed. 70 to 78 cervical spine injury can have a vertebral artery injury. That's because the vertebral artery runs through the spine. If you dislocate the spine, you most likely transect or dissect the vertebral artery. 19 to 39% of all spinal fractures, and how they look on imaging can really help us. This is the vertebral foramen on the normal side. You can see this fracture goes right through that, and then you can see where this vertebral artery is dissected. So this is a C1 atlas here. So you really want to make sure you do that to know if the patient may have a stroke or something from that. I'm going to quickly go through this just because I'm running close on time and I want to make sure I have time for Q&A. So the critical care, again, we talked about the pulmonary. C3 to C5 patients will need to be intubated. Remember, that controls the diaphragm. And then C5 and below, there's 2 ways you breathe, inspiration and expiration. So inspiration, of course, is important with your diaphragm, but expiration is actually contraction of your abdominal wall. So if you don't have good expiration, then sometimes even these lower level injuries need to be intubated and have just respiratory support initially. And as much as 70% of them will have these shallow breaths, and they're not really effective long term, and that's how they can decompensate. I'm going to kind of go through this quickly because I do want to talk about functional care. So hemodynamics and talking about neurogenic shock, I mentioned that earlier. This happens in higher injuries, T6 and above, and that's because that's where those sympathetic fibers are going, and they have unopposed parasympathetic firing. So essentially, you don't have any sympathetics, and it's all parasympathetic. So remember, sympathetic is flight or flight, fight or flight, and so you'll get vasoconstriction, but if you lose that, you'll have unopposed vasodilation. So these blood vessels will no longer contract very well, and you'll get hypotension, you get bradycardia, sometimes really scary bradycardia, and hypothermia because you don't have constriction. They start to lose their body heat because all the blood flow is going to their skin as well. And obviously, don't forget about other injuries that may cause hemorrhagic shock. If you do have a patient in the emergency bay with what you think is neurogenic shock, usually 1 to 2 liters of fluid before starting BP pressors, but most of them do need pressors. And like we talked about, keeping that MAPS up is extremely important. Sometimes you even need to have pacing pads for the bradycardia, atropine. I've had patients that you can simply just turn in the bed with a spinal cord injury and they can heart rate go into like the 20s or 30s or something like that. It can be very sensitive. Their parasympathetics can, and even something as simple as suctioning them can cause them to have bradycardia. There's all kinds of hemodynamic support, dopamine, dobutamine, epinephrine. Dopamine has the primary alpha adrenergic effects at low doses, with beta adrenergic at higher doses. So they're the most common that's used in spinal cord injury, but you can use any of them. Autonomic dysreflexia. This is something that I don't think a lot of physicians or healthcare providers understand. This is kind of crazy. These patients can have this reaction, sweating, hypertension, extremely high blood pressures from something very simple: blotchy skin, restlessness, confusion, agitation, headache. Even with something as simple as my mom had like an appendicitis. Obviously, she can't feel her abdomen, had no idea what was going on, but her skin started getting really blotchy. She started complaining, sweating. We knew something was wrong, but it's because, the body's response with a spinal cord injury isn't a pain response anymore. They can have this autonomic response to injury. It can be something as simple as not their bladder's full. They can get this autonomic dysreflexia. That's actually really common, particularly in patients that get in and out cath and don't have a permanent cath. I would argue that probably a distended or overfilled bladder is probably one of the most common causes. And then other types of infection, ingrown toenails is another one, can happen. Broken bones. My mom's had several fractures we didn't even know because she can't feel. So thromboembolism, DVT, very common. Obviously, these patients aren't moving. This is really what I wanted to talk about because I think this is important for us to understand and really puts a face to the injury. So it's about the patient. Patient is the center. But as healthcare has it, and one of my biggest things that I love to talk about is teamwork. It's not just the patient and the doctor. It's everyone on the healthcare team that's helping take care of them that's going to get them the most independence lifelong. It's not just the nurses. It's not just the speech therapists. You got your social workers, occupational therapists, physical therapists, family, dietitians. All these people play a tremendous role in these patients' recovery, and it's important that every single one of them is there to provide appropriate education and support. To achieve all these functional goals, there's so much that goes into these patients. Getting them motor and sensory recovery, getting them to learn how to live with their injury, integrate socially. We talked about some of those things earlier. And most importantly, giving them the best quality of life to deal with their injury. Patients with really high cervical spine injuries, think Christopher Reeves. These patients have limited head and neck movement, really can't even move their head very well, extend their neck. Sometimes speech and swallowing is affected. They may need PEG tubes, and they have complete paralyzation. They're paralyzed from everywhere. They need 24-hour care. They need someone there all the time, even head stabilization and trunk stabilization. Usually vent dependent. They can't talk because they're vent dependent. And total care with sip and puff chair. This is a picture of someone with a high cervical spine injury. This is a picture of a Hoyer lift. Many of you guys know what this looks like, but this is a device that helps assist lifting patients like this. Adaptive computer, ventilation, all these things are supplies that you need at home. And you can imagine these patients, if they don't have the support, they're not going to do very well at all. This is a picture of Superman himself. C4. So these are patients that have head and neck control. They can move their head, but they cannot move their arms or legs. They have shoulder shrug, so it can shrug their shoulders. They can breathe. Eventually, they can come off their trach. They don't really have good shoulder control, so even moving their upper extremities isn't easy, and the ability to cough is even disrupted. So even though they're trach independent, they can't really cough. So you have to do an assisted cough. I'm very good at the cod cough with my mom. Essentially, that's just pushing on the stomach and helping them cough because they can't contract their stomach. Again, 24-hour care. These patients may or may not be vent independent. They can talk because now that they don't have a trach, they can usually use their voice, very soft voice, which is, my mom can't yell at me anymore, which that's kind of cool. But they usually have a power wheelchair, Hoyer lift, need a lot of care and support. Adaptive computer. My mom is pretty independent on the computer. She has the mouse is on her glasses, so anywhere she looks, she can control the screen, and then voice activated mouse click and stuff like that. So Just technology has been really cool. This is a picture of her long time ago. This is probably from maybe early 2000s. C5, cervical spine injury. Again, as we go through these injuries, it's just improvement. So these patients have some movement of their elbows and can supinate their hands, and that can make a big difference. If you can supinate your hand, you can even put your hand on a control in a wheelchair and be able, if they can contract their biceps, to control their own chair. So going from complete needs to being able to drive yourself in a wheelchair, even if it is a power chair, can be really, really important. So if you have someone with a C4 to a C5, complete game changer. Even sometimes they can get adaptive equipment to help feed themselves. If they can feed themselves, that gives them so much independence. This is a picture of somebody with a C6 injury. So again, you're getting wrist extension, and as these things goes along, these patients become more and more independent. If you can get wrist extension, you can actually drive your own chair. Even if you can't use your hand, you can use your wrist to flex forward and to actually use a manual wheelchair. This is a C7. Again, more improvements. You get more flexion extension of the elbow, maybe some better hand function, but still not a lot of good finger function or even trunk support. But these patients are usually completely independent. They can even do their own bowel regimen, which is incredibly freeing for someone. And a lot of times they can complete their own wheelchair transfer. So you go from someone from a C4 injury who is completely dependent to a C7 that can do almost everything themselves. Those 3 levels, remember what I said, the 24 hours getting them stabilized. If you can preserve just a couple of levels, it can be tremendously difference in their long-term function. C8, T1, these are right at the cervical thoracic junction. They usually have some weakness in the hands, but it's usually pretty good. And these patients are almost completely able to use their arms and legs. High thoracic injury, that means they usually have less control of their upper trunk, and they may have limited walking because their trunk support isn't that great, but they can even drive a car because they have complete use of their arms and ability to transfer themselves in and out. Lower thoracic, they have even more trunk stability. So some of these people might be able to actually walk with braces because they can control their trunk of their body. And then, of course, the lumbar injuries, these are variable depending on how much movement you can get in your legs. And you can have patients that may only need just help, with a couple of things a day or something like that. And definitely should be able to walk with modifications and have a pretty good quality of life. Sacral injuries really varies. Even someone with a sacral injury can be tremendously devastated by loss of bowel, bladder, and sexual function. These are really, these are very hard injuries too, even though they have complete, you might say, oh, well, they can use their arms and legs, it's not that bad. But if you lose your bowel and bladder function, it actually is, it's pretty devastating. So all of these things I just wanted to kind of talk about because I think as providers and as physicians, we don't understand how maximize just going from one level injury to the next can really change the functional outcomes. So our goals are to achieve the maximum functional outcomes and improve their quality of life. Long-term complications, skin care is really, really important. Nutrition, bowel and bladder control, renal stones. If any of you guys follow me or work at this hospital, my mom she's 30-something years post-accident and just had urosepsis because of a kidney stone. So these are issues that are persistent. Autonomic dysreflexia maintains lifelong. Range of motion is important. If you can't contract or move your legs and you don't do passive range of motion on these people, they'll get extremely contracted arms, legs, hands. And then, if you have a hand that's severely contracted, you can even get pressure sores in the palm of the hands, which could kill you because you're not passively doing that. And that's something that the providers, the people that care for these patients have to do. And that's every single day. You have to do movement, passive range of motion of every single muscle group that doesn't move. So you can imagine why these patients typically come up long-term when the legs are curled up, or this applies to stroke patients as well. Spasticity is a real problem. they often are on. Medicines for spasticity and pain like baclofen. Depression's a huge one we talked about, and sexual dysfunction extremely affects mental health as well. I'll skip through some of this. Research, we talked about the primary injury and the secondary injury and how we can affect these levels of cascade, and the different ways we can approach treating spinal cord injury can really affect. And I think it's exciting to see how research may change how we can help maximize functional goals in these patients. This is, the Miami Project to Cure Paralysis. This is their logo. I loved it. When I was 13 and my mom was in her accident, I thought this was like the coolest thing because I thought one day my mom would do this. But this isn't the goal, always. It is the goal, ultimate goal. But really, the most important goals is really trying to make these people as functional as possible. And something as simple as giving someone a hug is the ability to do that can be mentally very helpful. Going to the bathroom, driving your own car, playing sports, transferring yourself are all really, really important things that I think a lot of us take for granted. Quality of life, is it a definition and measurement? This is just a paper that kind of helps explain this. And I have a passion for this type of discussions as well. It's just really important. If any of you haven't read The Diving Bell and the Butterfly, it's super easy to read. You can probably read it in like an hour. But it's just a really powerful book, probably one of my favorite books, about a man with locked-in syndrome that wrote a book and his experience being a patient with locked-in syndrome. It's like 200 pages. Highly recommend. It just kind of gives us a different perspective. Again, revisiting this, this is July 14th, 94, so 1 month before my mom's injury. And then, again, the pictures of her accident. And then these are pictures of her now. And she's still doing well. So this is actually us on her birthday about 2 weeks ago. And, it's a hard thing to do. It's a hard thing to take care of these patients, being the provider, but being the patient or being a family member of these patients, we appreciate everything that we do as providers to take care of these people and really make them as independent as possible. So these are my references, and I'll leave it open to Q&A.
Dr. Grunch, do we have questions? We have a question.
No, just a quick point. It's incredible. NASCAR has cervical collars for the race car drivers, and we don't have anything like that in today's cars, which is kind of funny. It would probably prevent a lot of, cervical injuries to begin with, because by the time nanoseconds go through inflatable bags, they're not going to hold you. So the cervical collar probably be one of the best things, and they can do it fairly cheap. The other thing is, where are we going with AI? Again, Elon Musk and nanotechnology or microchip technology to supplementing these nerves. And one of the things I remember back, I don't know, it was 10 years ago, whatever. I like to read a lot. I like to keep up. I like to be ahead of the curve. They were transplanting nerves from cadavers and they were having, I don't know, began to read, they were having pretty good results, and all of a sudden it was gone. They don't read much else.
Yeah, so I think, I'll just speak briefly on the Neuralink. I think it's obviously people have very strong feelings about Elon Musk one way or the other, but I will say that the Neuralink is kind of exciting technology, in my opinion. Essentially, that's where you put microchips in the brain so they can detect firing of the brain says, hey, I want to move my arms or legs. And the Neuralink detects those neurons firing and then delivers those signals somewhere else. So whether or not that's adaptive technology or something in the mind that's controlling the computer or even a robot or something that might make these patients more independent, I think it's fascinating. And he's enrolling patients, in clinical trials now to do this. I think it'll be interesting, and, whatever happens, we'll learn a lot from it. So.
Thank you for that. Do we have any other questions or comments?
Thank you, Dr. Grunch. That was a great talk. I was going to piggyback on the previous comment. There was a period of time where I saw some literature on patients, mostly in Korea and China, who were getting scaffolding with stem cells in them to sort of try to link the broken parts of the cord. And then again, it sort of fell out of things. So I'm not sure where that stands, and if you have any insight into that.
Yeah, I don't know if you were here earlier, we were just talking that they had released a clinical trial here in the U.S. at Griffith University, I think it is, about a week or two ago, doing that same thing with stem cell technology right at the time of injury. So it's interesting.
Any other questions? Just raise your hand. Oh, we have one back here.
Betsy, that's great talk. Always awesome to hear you talk about this with so much passion, and we're all learning from you. And your mom is one of the coolest people we have met.
Thanks for taking care of my mom.
No, absolutely, absolutely. So I think this is all very encouraging to hear, and I think we have so many medical students, nursing students, all that, and I know you do a great job of educating. Do we have like a path of understanding spinal injury, and how do you think we can spread even more where, wherever you go, there are some charts, it feels like still we have a lot of opportunities when it comes to, really always following, like you just said, like very simple. When you have a car wreck, just stabilize the spine, put a cervical collar, things like that. So I'm sure there is like community education and all that going on, but we hear talks like this, and I think there are education sessions going on, but can it be more visible wherever we walk in ER units, wherever we are?
Yeah, I think that, where we are with spinal cord injury really hasn't changed much. I've given this talk the past 15 years, and it really hasn't changed, which is kind of sad. But to your point is, I think awareness is improving, but the more we continue to educate, Lauren told me earlier in this, Grand Rounds talk, we talked a lot about stroke, but why don't we talk more about the spine? Why does no one want to talk about, about the spine? And even with simply neurological examination in the emergency department by our providers, I think the neurological system is complex, and I think it's intimidating to a lot of people, including, nursing and physicians that are not in neuro. And I think anybody that's in neuro or neurosurgery really understand how lacking we are in other providers' ability to even perform a simple neurological exam. It's really not a very challenging thing to do. Most people that are in medicine know how to read an EKG, but they don't know how to do a good neuro exam. So I think just the simple awareness, just us simply talking about it, is really important. And that's not just here in this talk, but even, to paramedics, to first responders, to, hey, these things definitely happen. It's not just random, I saw 25 years ago this patient that wasn't stabilized correctly. No, we see it every single day. Every single time I'm on call, I see something misdiagnosed and undertreated, and it's a lack of awareness. And a lot of it just has to do with lack of education. So the more we talk about it, the better.
One last thing, it blew my mind completely. By age 50, your brain has completely regenerated itself, which blew my mind. I said, no, this is false. And I really delved into it, reading, and yes, it's true. By age 50, if you don't smoke, drink, do heroin every day, it should regenerate normally. See what I'm saying? So
the patient who might or might not be able to, but some other family member who's around, if they know what's important, they can speak up at the time and maybe help preserve a few people when the provider hasn't done it for a long time or whatever.
Yeah.
It's community awareness. What I'm taking home from this as an elderly person is that my friend who's fallen down 3 times, she looks like she went to the fights. So far she's walking around and hadn't done anything bad, but I don't think the fact that she could have had a subtle injury and a devastating outcome was probably
even on her mind.
anything she thought
Right.
about or anything anybody else thought about.
Right. No, I definitely agree. I think,
I mean, I better not okay.
yeah, no, I mean, like I said earlier, in patients over the age of 45, the majority of spinal cord injuries is from fall. And I won't even talk about spinal fracture, but the majority of time, we see a lot of older patients that have a ground level fall and have C2 fracture or whatever the case may be. The bone's osteoporotic as we get older. And you think about that patient that I had this weekend, that simple fall down that one step that's in her home that's been there for she's lived in that house 40 years, but that sunken in living room, she's fell 3 times in the past 3 months. And it didn't take until she broke her neck until it's like, okay, maybe this should be fixed. So if you have older people at home, older people in your community, simple things to help make modifications to prevent fall is super important. And to your point on awareness and giving this talk, one of my passions is social media education. And I think we can reach so many more people by me standing up here in Walter's auditorium in front of however many of you guys are here or even online, but really speaking to a broader platform to continue to educate on important topics like this. So
Another point to make is I've had 2 knee replacements, one in April 2023 and one after Thanksgiving in 2023. I'm still going to PT, and what I've been doing since March is working on balance, which now in October is finally beginning to come around. So helping people with and it's very important. It's as if I've had to learn to walk again.
yeah, rehab is extremely important for any type of orthopedic or neurological illness.
Thank you so much, Dr. Grunch.
Thank you.